Thank you, Mr. Speaker. Full disclosure, I testified to Judiciary Committee the other day, and the gentleman from the 67th asked me if I belonged to West Virginia ACOG. I do belong to ACOG itself. Some of my dues do go to West Virginia ACOG. I've never formally applied to them, but I assume that I am probably a member, or at least on the rolls. So I misstated that previously, saying that I wasn't, but I may be. So getting that out of the way. I have, over the weekend, while each of you were diligently going over all the other bills, while I was taking care of my practice delivering a few babies, I took the time to read over the ACOG practice bulletin. I was able to log on to the site and look at all the different reviews. And from ACOG practice bulletin 135, this is the most recent one, it mentions, though, that these guidelines, this is quote, "These guidelines should not be construed as dictating an exclusive course of treatment or procedure," unquote. I wanted to give you a little bit of facts first, just so the members here have some background. They've heard different numbers, but I wanted to state some of the things that came right out of that committee opinion. About 4% of abortions occur from 16 weeks or later. That's what's in the second trimester. So you're only talking about 4%. After 21 weeks, 1.3%. Mortality rate, meaning mother dying, is 0.6 out of 100,000 abortions. Childbirth, 14 times greater than what it would be for abortion, just to put it in perspective. Now, abortions that are performed less than 8 weeks, the mortality rate is 0.1 per 100,000, but over 21, or at 21 or over 21 weeks, 8.9 over 100,000. So there's a relationship between how many weeks of gestation to what the mortality rate is. So the further you get, the higher the rate. Most of these terminations that are done in the second trimester have a higher rate. Now, in 1973, when they mentioned the Supreme Court decision in Roe versus Wade, the same committee report quotes, "By the late 1970s, researchers had demonstrated the safety of D&E and concluded that it was safer than the medical abortion techniques used at that time." This is in the late 1970s. They also mentioned afterwards, under methods, that, quote, "both surgical and medical methods of pregnancy termination can be used in the second trimester," unquote. And also, quote, "limited evidence suggests that the vast majority, 95%, as quoted by the gentleman from the 67th, of second trimester abortions in the U.S. are performed by D&E. However, terminations by medical abortions may be underreported." As the lady from the 51st had mentioned, that a fetus that may have no head or no heart, or no brain or no heart, most of the cases of medical abortions are performed to keep the fetus intact so as to determine what anomalies or genetic malpresentations were there. So there are reasons why these are done that way. Now, again, it does take a certain part of skill to do a D&E, and many places do not train their providers in how to do that. About 30% of residencies don't have opt-outs for abortion procedures, and about half the residency programs don't even train their residents in how to do a D&E. So it does take a certain level of skill. And as some of the other people have mentioned, there are significant risks to those procedures. Now, ACOG and West Virginia ACOG, along with the AMA, don't like any interference with the physician-patient relationship. And I, for one, don't particularly like it either, but I realize there are guidelines we have to go by. Main concerns regarding abortion are access to care, facilities that are available, people that are trained to perform the procedures, transportation to and from these centers, cost, insurance, just to name a few. I will submit to you that the physician-patient relationship with someone obtaining an abortion, they're usually meeting that person for the first time, so it's usually not a long-standing relationship. That doesn't negate the physician-patient relationship, but again, it's not something that's usually been long-standing. Now, government interference in medicine, particularly to my practice, Perinatal Partnership and ACOG are already pushing that we can't do elective deliveries before 39 weeks. And CMS regulates that we have to have certain codes, diagnosis codes, in order to do that. That takes a lot of the decision making out of my hands when I'm trying to determine the general scope of what's happened with my patient. I live by that, I have to go by it, that's part of the rules. But don't doubt for a minute that if I felt I had to intervene, I wouldn't do so. And I suspect that many providers that may do abortions for their patients wouldn't hesitate to do the same and suffer the consequences. Tubal ligations. Medicaid patients, the federal government dictates that we have to wait 30 days, have a consent on the form that they signed 30 days before we could do a tubal ligation. They require that. That's because of the person's right to their privacy as far as their reproductive abilities. However, if I'm doing a C-section on someone and they wanted a tubal ligation and I didn't have those forms signed by the government, I couldn't do it. Even if it's against my best judgment, I'm subjecting that person to another procedure, something that I didn't plan on doing. Cloning, researchers, we have moral boundaries as far as what we're allowed to do from research. Euthanasia, how many patients that I've had to deal with in oncology, cancer patients. I mean, I've been faced with that. You're not allowed to do that. We set those boundaries. So my thought is there are things that we are setting. For this particular procedure, all this is saying is that if you have a live fetus, you're not going to dismember it. Now, this was brought up also about the term dismemberment. It's not a medical term. In the same bulletin, they describe it as disarticulation, for those of you that want to be specific. In any case, all this is saying is that you have to either terminate the fetus before you perform the abortion, or you use another technique. And the same bulletin reports the different techniques on how you can terminate the fetus. So this bill does not prevent someone from doing that. Certainly someone that is going to terminate the fetus is not going to be against injecting potassium chloride or digoxin into the fetus. So I don't see that this is a boundary. It does give the medical exception as far as emergency, that you can still do that. I don't have a problem with it. I know some of my colleagues do, but as I mentioned in the judiciary testimony, they didn't poll me. And I'm sure they didn't poll many of the other members of ACOG in West Virginia. Thank you, Mr. Speaker.